Hi, this is Paul Johnson.
And Marcus Armitage.
This is our presentation for the Pathology and Clinical Reasoning module. Our patient is a 40-year-old triathlete in remission from skin cancer complaining of shoulder pain. We know that triathlons are endurance events consisting of swimming, cycling and running.
We will be reviewing the prevalence and type of injuries in triathletes, mechanism of injuries, the likely pathology and any alternative possibilities caused from cancer.
So we started our review looking at a study from 2013 where 174 participants at Norseman Triathlon were studied over 26 weeks in a prospective cohort study. During this time, it was concluded that 56 reported overuse injuries, with 20% reporting an impact in their training volume, performance, or complete inability to train or compete at all. So the conclusion was the majority of injuries were in fact overuse injuries, with the prevalent sites being the knee, lower leg, lower back and shoulder. We then looked at shoulder injuries specifically within triathlons or triathletes, and we looked at a 2018 retrospective study of 193 amateur triathletes. This study looked at 12 months of training habits and competition, and the conclusion was that 86% of all overuse injuries of the shoulder were thought to be primarily associated with swimming. So we're now understanding that injuries are quite often overuse chronic injuries, and when it comes to the shoulder, that swimming is associated. So we then looked at a 2012 retrospective study of 120 competitive swimmers. 65% of all in-season gradual injuries reported were shoulder injuries, with gradual onset injuries being 2.7 times more common than acute injury. So it's clear that overuse injuries are typically more prevalent than acute injuries. So having looked at swimming or swimmers, we then looked into swimmer's shoulder, which presents as a subacromial impingement involving rotator cuff tendon, bicipital tendon or subacromial bursa.
Symptoms for swimmer's shoulder are pain in the anterior lateral aspect or the subacromial region, the painful in abduction between 60 and 120 degrees. Any impairments are included with glenohumeral hypermobility or instability, impaired posture, and impaired rotator cuff strength. Now, based on this research around this injury, there are 4 pathologies to look at.
So the first pathology we looked at was subacromial bursitis. Now, with all 4 of these pathologies, there are common trends in regard to mechanism of injury being chronic and overuse, and also the history presenting with pain overhead. So we looked at the special tests available. So for this, we have NIRS. So NIRS is where you take the arm into passive flexion, and if pain presents in or is reproduced in the shoulder joint, this would be positive for subacromial bursitis. And second, we have Hawkins-Kennedy, where the shoulder is taken into passive internal rotation, and again, if pain presents in the shoulder joint, this would also be positive. However, the specificity of these tests are relatively low, so we would also consider the possibility of previous trauma, as this can also be secondary to that. And finally, the localized pain being in the subacromial region.
Secondly, we have primary impingement syndrome, which we can look at NIRS and Hawkins test, but as the specificity is low, we can have a look at the empty cans test, also known as JOBS. The empty cans test, you have the patient have the shoulder in 90 degrees flexion, 30 degrees abduction, and thumbs facing down with slight downward force. Now, any positive sign for this test is any drop or fall of the arm. We can also look at the poor posture or shoulder mechanics and any history of anterior lateral shoulder pain.
Third is rotator cuff tendinopathy. So again, we have the possibility of using JOBS, 82 specificity, so there is a strong positive with that. If we did want to look at specifically which of the rotator cuff tendons was potentially the factor or issue, then we have a couple of options. We have the painful arc, which would look specifically at the supraspinatus, and this is where the arms will be taken into active abduction, and pain, if reproduced between 60 and 120 degrees, was found that would be positive for this. Secondly, we've got the Gerber lift-off test, which is a very strong specificity of 98%, which is where the arm comes behind the body, and if the patient has an inability to take the arm away from the body, that would be positive for subscapularis weakness.
Lastly, we have the biceps tendinopathy, which is any pain in and around the biceps and bicep tendon. The two tests we have for this are the SPEED test, which you have your patient stood, arm going into flexion with the wrist in supination, and any pain with resisted on the forearm, with any pain in the bicipital groove being a positive sign. Secondly, we have the Jurgensen's test, which you have the patient have their elbow at 90 degrees with the hand in pronation and is slightly resisted into supination. Again, any pain in the bicipital groove is a positive sign.
So in summary, looking at our differential diagnosis, we know that the mechanism of injury is chronic, with the history being painful movement overhead. Depending on history of location of pain, we have a number of different special tests to allow us to identify the particular pathology for this. So having looked at injury pathology, we wanted to have a quick look at other possibilities involving cancer and treatment of cancer.
When it comes to cancer, there are two types, melanoma and non-melanoma. Melanoma, 16,000 diagnosed each year in the UK alone. It is the fifth most common cancer in the UK and in second most common in adults below the age of 50. Typically develops from any existing moles the patient may have.
Then you have non-melanoma. This is far more common with 147,000 diagnosed each year. It doesn't appear on the cancer league table just because in most cases it's not too serious. It does present in two different types. You've got basal cell carcinoma and squamous cell carcinoma, with incidence rates highest in 90 plus and BCC making up 75% of all diagnosed. And this can manifest from existing moles or new moles or lesions that have recently appeared. In regard to presentation of skin cancer, we have on the left a representation of both male and female prevalence. You can see on the left there that prevalence is far higher in males in the upper region, so that if our patient is in fact male, there's a higher percentage that it may in fact be closer to the shoulder or potentially in that region. Down the middle, we've got the different presentations of the cancer, so something to be aware of when assessing or treating, especially around soft tissue. And finally, on the right, we've got the various stages, starting from 0, where it affects just the outer layer of the skin or the epidermis, and presenting all the way through to stage 4, where it's actually gone into or spread into the lymph nodes and other organs.
Main treatment for skin cancer is surgical. They remove the cancer, and if the cancer area is large, then a skin graft may be required.
So surgery treatment is typically the only treatment needed, although in rare cases, if the cancer does reach stage 3 or more, then lymph node removal is a possible treatment. If this is removed from under the arm, then shoulder stiffness and pain is one of the most common problems associated with this, along with possible reductions in range of movement post-surgery, with discomfort and healing lasting several weeks. There is also a possibility of long-lasting problems with pain following lymph node surgery, which means there is a possibility that if our patient has had this type or stage of cancer and this treatment, there is a possibility that essentially the pain could be as a result of this and not actually an injury pathology at all.
Red flags to be considered when looking at a patient with skin cancer, there are two types. Later stage cancer, which would be looking at any unexplained night pain or any unexplained weight loss.
And also we want to consider local reoccurrence as well. So this could be anything from moles changing shape or colour, essentially what we showed you in a previous slide with what we'd be looking out for. And in any case, we would refer to a GP or medical professional for further investigation before treating. Looking at yellow flags finally, there are a few factors to consider. So looking at the biopsychosocial model, self-esteem issues and coping strategy issues could be something to consider, along with physical health, immune response, and also in regard to social, their support network, peer group, job, etc. This all could come together to increase pain anxiety or their inability to cope with trauma following having cancer.
In conclusion, with the patient being a 40-year-old triathlete in remission from skin cancer, complaining of shoulder pain, based on the evidence provided, the likely mechanism of injury is a chronic overuse with a gradual onset, brought on by potentially swimming being the aggravating factor. Type of injury is a subchoroidal impingement.
Also to consider the possibility of the stage of cancer or treatment, and that if stage 3, treatment could have been removal of lymph nodes, and if that was from under the arm, then shoulder pain could be the consequence of that, and long-lasting shoulder problems could also be a factor. Finally, biopsychosocial factors from the trauma of cancer should definitely be considered when working with this individual. Here are a list of references, and that concludes our presentation. Thank you very much for listening.